Welcome everyone to today's webinar on healthcare workplace transformation for clinicians and knowledge workers, sponsored by Lenovo Health and Intel. I am Maggie Moran with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our panelists. Wendy Bonner is Solution Architect for the Intel Health and Life Sciences team. She works with providers and payers and industry partners around the world as a trusted advisor on the development, implementation, and scaling of end-to-end healthcare solutions. She advises Intel customers and partners on creating healthcare solutions on secure, reliable, interoperable, and scalable architectures. Bradley Dick serves as Chief Information Officer to Resurgence Orthopedics. Bradley's role involves strategic planning, budget, and staff management, overseeing project implementation and ongoing support of the network, desktops, and business applications. With almost 2 decades of experience in the field of information technology, Bradley has served as Director at Large to several advisory boards, including Georgia HIMSS, the Georgia CIO Leadership Council, TAG Cloud Board, and is one of the founding members of AT&T's Healthcare Advisory Committee. Andy Nieto is part of the healthcare team within Lenovo, responsible for fusing clinical and technical knowledge into solutions development. He has extensive experience in architecting, evaluating, and implementing solutions resulting in long-term organization success and improved patient outcomes, and a passion for improving the flow of information inside and outside of clinical networks. Finally, we are pleased to have Scott Becker, publisher of Becker's Healthcare, here to moderate today's discussion. Scott, I'll now turn the floor over to you to begin today's presentation.
Maggie, thank you so much. We've got about 45 minutes. We've got 3 great panelists in Wendy, Bradley, and Andy to talk about digital transformation and the impact that this transformation will have on patient experience, clinical collaboration, and the knowledge workers in healthcare organizations. I'll just give a couple starting points, and then we'll get into the question and answer of the 3 panelists. We're in a spot where the transformation that's occurring in terms of digital transformation will continue to change the world of healthcare, deliver positive impact in terms of clinical workflow productivity, leading to real-time collaboration for clinicians within health facilities and beyond, and leading to lots of different IT advances. Well, let me do this. And as we see in all of our workplaces, and it's on the first slide here, millennials, and really all of us, we see it in communities up to a certain age and even a lot older, workplace tech and the ability to use workplace tech well and do your job well has become fundamental to having people engaged at work and excited about work, and quite frankly, to worker retention. If your tech falls behind in a workplace, you quickly find that your retention levels of employees also fall behind as people know they can get better tools and tech to work with at other places, and it's just become a reality of part of the workforce today. With that, let me get started with our questions and our panels. I want to remind our audience, first, thank you for joining us, and then 2 other things. You could always add a question into the question spot on your screen, and the last 15 minutes or so we'll spend with question and answer the audience. Second, I want to thank Lenovo Health and Intel for being the sponsors of today's webinar, so thank you very much. With that, let's get started. So, Wendy, I'm going to start with you and then go to Andy and Brad. The trend towards digital transformation is redefining the way organizations work. How does this move towards digital transformation? How does this impact health systems? Wendy, let me ask you to get started with that.
Sure. Thanks, Scott. With health systems moving towards these digital workflows and being able to generate data from those workflows, we can now use that data and use it for downstream analytics and to optimize operations, financial performance, or clinical outcomes. And we're seeing many healthcare organizations moving toward predictive modeling around patients. Common use cases are including maybe predicting sepsis or respiratory depression, and also identifying those high-risk patients. When you can identify those high-risk patients, then that information can be used to route people to the most appropriate care. We can predict when we're going to have no-shows that are wasting our resources within the hospital operations, and we can also forecast and allocate those hospital beds more efficiently, excuse me, to house the patients and reduce their length of stay.
Thank you very much. So, Andy, some of your thoughts, Andy Nieto, some of your thoughts on how clinicians can benefit from workplace transformation. What do you see with clinicians and what's going on digitally?
So a number of things are really starting to get to the hands of the clinician. One of the things that I find very exciting is some of the things that we expect in our personal lives, apps on our phone that give us real-time access to information, are now appearing in our clinical systems and our clinical workflows. So the ability to, at the touch of a button, see not only your the person's health record, but statistics of what's going on around them, the resources to bring care to the forefront, and then different tools to be able to do that. So we went from paper to computers, and now we see everything from desktops to all-in-ones to tablets to mobile phones being avenues for delivery of care. And so as this digital transformation has taken place, we also see the opportunity for care coming back to the hands of the physician. It really stepped directly to the science for quite a while, where we're really focusing on the computer, and now the technology is actually pushing back into the hands of the clinician. So whatever they're comfortable using becomes the important tool and frees them up to spend their time focusing on the patient. And I find that to be one of the most exciting things coming out.
So the best hope is the technology becomes so easy for them to use that they get time back to really work with and deal with patients. I mean, that's as good as it gets.
That's the goal, absolutely. And hopefully the technology becomes transparent from the patient's perspective. So instead of them seeing the back of the clinician's laptop, what they're seeing is the physician's attention.
Got it. Thank you very, very much. Bradley, anything that you could add on to that in terms of what you see? Because we've got great presenters from Lenovo and Intel that see this in a broad range of systems, but you're actually in the trenches running this sort of information and serving as CIO for one of the most respected, huge orthopedic groups in the country. What do you see on the front line in how digitally things are changing and how your clinicians are working with that, whether it's allied nursing staff, physicians, whoever it is throughout the system?
Thanks, Scott. I guess I just want to kind of echo the original comments that they had, both Wendy and Andy. They're completely right there. With the transformation and the additional data that we're getting, we're finally to a point where we're actually getting data from other points of care. We're finally able to kind of collaborate and have all that data come down to that provider from multiple settings. And really kind of answering that, I think that, since I've got engaged in healthcare IT, that's always been the kind of the goal, was to get the right data to the provider at the point of care with the patient. And, obviously making it as transparent as possible, because I think that that's really kind of that's always been, at least personally, has been my expectation, when you're engaging with the clinician, provider, physician, to have that, rapport with them. That's really kind of the key thing. And that's one of the things that technology is finally getting to. I think that one of the key things is we're starting to get data from all these different other places, And now it's really about using those systems, like we were talking about before, using the analytics to identify the key information. We don't need every single piece of data from the patient's chart. We need the relevant to this episode of care or to this, entire incident at the provider's fingertips and as transparently as possible. So I think that's really kind of the next forefront is going to be along the lines of figuring out what's relevant to this case, what's relevant to this setting of care, and getting that to the people that need to make the decisions with that data.
So they really get the right information at the right spot without a lot of difficulty. Because you hit it exactly right. The overloading with data is a problem. But comment on that. The right data at the right spot. Is that what I'm hearing?
Exactly. I mean, the big, it's now that we've gotten everybody on EHRs and everything. Now the big thing is, provider burnout. Because I mean, there's nothing that'll burn your providers out more than having them have to do these administrative tasks of reconciling, 7 different charts from, 3 different episodes of care and all these different, data. I mean, it's great that we can dump data from, setting to setting, but a big data dump, is only as valuable as what can be distilled and synthesized to be relevant to this care.
Thank you. Let me move on to another question, and let me first stop for a second. In terms of how digital transformation is impacting healthcare workers, Wendy, anything you wanted to add to that caught your thoughts as you listened to Andy and Brad talk?
Yeah, thanks. I really agree with both of the statements made, but what really caught my eye was around we're using artificial intelligence now, not to replace the physicians, but really to automate that monotonous work. And it's exactly where it's applied the most and really can make the most impact. So experts don't have to go in and tag treatments. We can use artificial intelligence to wade through all that reams and reams of data. 30% of all the world's data is healthcare data. And we can really use artificial intelligence to wade through it and point out the relevant information that you need with that treatment care that's going on right now. So yeah, that was a great point.
Thank you. So really to the point of not being overwhelmed with data, but using the AI and using the tools to get you to the right data at the right person, the right time. Fascinating. Thank you. Andy, anything you wanted to add in?
I think the only thing I would add, and this is a great panel with just incredible people on it. I think the only other thing I would add is that as we look at the next steps, I think we're going to start seeing more clinicians driving expectations. I think we're going to see more now that the power is coming back into their hands, and now we're starting to see more leveraging the technology in the workspace. I think we're going to start getting more feedback from the clinicians themselves to start guiding some of this, and I'm really excited about where the future is going on it.
Thank you, and I think that's a great point, and more that's coming not from the IT department, but from the clinicians in terms of what they want and what they need, and clinicians of all sorts. Let me move on to the next question, and it goes to this concept of retaining employees. It's on the clinical and business operations side. Both millennials and older workers say that workplace tech would have an influence on what job to take, on whether to take a job. And Andy, let me start with you. How can health systems better provide an efficient and better technology to better respond to workers' needs? I know that's a broad question, but how can they approach this or attack this to better respond to worker needs?
Well, I'm going to answer that in 2 parts. And the first part, the way I'm going to answer it is that there are new and ever-evolving methods of acquiring technology and leveraging technology. We're seeing more and more growth in the healthcare industry of this concept of device as a service, or leasing products in a way that lets us get more modern technology, shorten the refresh cycles, shorten those windows where we're having to fund capital investment for technology in healthcare. So my first part of that answer is I'm going to strongly encourage health systems to really work with their partners and look for concepts like device as a service that allows you to put a brand new device, a cutting edge device, in the hands of your key employees more than once every 3 or 4 years when the refresh cycle comes around from a capital investment. That is really changing kind of that perception. I know that within my world, people who are getting towards 18 months on a cell phone, they're ready for the new cell phone. So if you think about having to keep a cell phone for 4 years, which would be a typical refresh cycle, that becomes a really, really strange concept to the consumerism age that we're really in. The second thing that I'm going to say is to really have a robust mobile device management policy and bring your own device policy, and engage the physicians and the clinical staff that you're really trying to retain to find out what they're looking for and they need. If you order a bunch of laptops and they all want tablets, you're not in sync. So having kind of a buying committee that says, this is the way we want to work, and finding a hardware or technology partner that helps get you there is a really, really good way to engage them, make them feel part of the process, and drive that forward.
Let me ask you a question on, you mentioned really two things. First is the movement towards refreshing technology, and you move towards different models of doing this so that people aren't waiting 3 or 4 years for the next hardware update. And a fascinating point, I saw that the time that people are using their phones, holding on to them, has expanded to almost 3 years just because people can't afford to make the changeover. But a fascinating point you make about technology. And then the second point you made was, and this is the right question for you, is being receptive to the concept that, what devices do people want to use, and having a very active mobile device policy. And how do you put sort of balances on that to accommodate every kind of mobile device somebody wants versus not putting so much stress on your IT department? How do you hit that balance on the mobile device policy and what you accommodate and work through and so forth?
So great question. The avenue that I usually recommend with my clinical partners is that first set the parameter with what makes sense. If you're in an environment where the minimum screen size is 12 inches on a tablet for a particular application or tool, you can't say anybody who has a 4-inch Kindle Fire can get online. So you have to set structure and then work within your evaluation team to select the right components. The second part is we're leveraging virtual desktop, virtual application, and virtualized environments so well that managing data and controlling that access while giving a consistent user look and feel and a consistent experience is really an art, and having the right partners to help you achieve that delivery of a consistent look and feel, regardless of whether you're on a MacBook, a Lenovo laptop, or an iPad, right? So setting your standards, partnering with your purchase team, your tiger team, if you will, of experts that are inside the facility to get that leadership position, and then helping guide those devices. And the last component is you have to set some very specific rules. Your mobile device management policy, you have to have very set rules. And some, unfortunately, with security and privacy, we have to be very stringent in those rules. But as you're setting those, it will help you define what it is you're trying to accomplish.
Thank you very much. I've got a follow-up question that's really for you and Wendy, and then we'll come back to Bradley in a second. We're seeing throughout the world increased care collaboration between health systems and between office, sort of in some ways the breaking down of silos between the hospital, the clinic, different hospitals, joint use of pediatric programs, different types of things that systems are doing. What types of technology devices, and Andy, I'll start with you, software and infrastructure are needed to support this work amongst different institutions? And then similarly, Wendy, I'll ask you the same question to get your thoughts on this too. So Andy, let me start with you.
So the first kind of technology or infrastructure expectation that I would have, especially if I was in Bradley's role as a CIO, would be that my software partners adhere to documentation and clinical standards for the way information is stored and shared. The second critical component there is really having a goal of how do we deliver, not the position of let's first see if we're in compliance. It's a nuance, but it's an important nuance. If our goal, our focus is delivering information for the care of that patient, it kind of empowers us to connect to all those that you need to connect to, and have that expectation of our vendor partners, whether they be our EHR vendor, our lab vendor, our ACO vendor, whoever it is, that they help drive and facilitate that. And then finally, don't be afraid of recognizing who the other care provider is and leveraging every means necessary. That may include that curbside consult, that 5-minute phone call to the other clinician, because at the end of the day, caring for our patients, recognizing them not just as patients, as people, and driving healthcare and wellness forward is what we're all about.
Thank you. In terms of the and Wendy, let me turn to you, and I'll come back to Andy in a second. Wendy, some of your thoughts on technology, devices, software infrastructure. Andy had made the point, and this is something that's become an absolute imperative more recently. 10 years ago, people didn't push towards this, and it cost them a ton of money fixing. He made the point that with your vendors, you have to make sure on the front end that they're planning and preparing for interoperability. Andy, that's what I heard you say is a critical component. 10 years ago, people didn't do that, and it's caused millions and millions of hours of fixing on the back end. Wendy, some of your thoughts on technology, devices, software infrastructure to support collaboration. Andy, can you hear me?
Yes, I can hear you just fine. I'm not sure if Wendy is
sorry.
on mute.
Sorry.
There you go. We might have had you on mute for a second, Wendy. Thank you so much.
Sorry. I definitely agree that interoperability is something we need to plan for, and it's a key piece of how we can collaborate. But I want to stretch out a little in terms of thinking of the next type of things that we need to be planning for in the hospital. And I'm thinking of networking and 5G, because we've been talking to our policymakers about this and getting them to plan. And it's something that the hospital should also be thinking of, in that 5G is still in development, but it's going to be a reality soon. And we're going to be able to take what we've built today in the data center for virtualization and virtualization of desktops, virtualization at the edge, and software defined, and being cloud ready, and bringing in artificial intelligence. We're going to be able to use all of those components to transform the network from end to end and deliver 5G. So it will enable in the hospitals wireless broadband services as an alternative to Wi-Fi. And so we'll have better collaboration experiences then, because of that low latency and control that 5G will bring. And it's got some new aspects to networking that we haven't had before with 4G. And one is that we can slice the network layers into vertical slices, where you can separate out different healthcare needs, matching the speeds to the use case and the security level to the use case. So you would maybe have a slice for connecting up the medical devices, connecting up real-time applications in another slice, video streams in another, and the wireless broadband throughout the hospital for your mobile devices in another. It's similar to what we do when we're providing virtual desktops. We also have a horizontal slicing component to it, and that offloads the compute that needs to happen at the edge with the edge device. So you can have a thinner device, a smaller device. So healthcare workers won't have to carry around as big a device with as big a battery, and we'll be able to offload some of that to those horizontal slicing layers. So smaller mobile devices with lower battery requirements. We're going to have new use cases around telehealth, going out into underserved areas, visual command centers for monitoring, that streaming video. And it's going to be how it was when we broke into 4G, and there was an explosion of new apps and the application of all of the delivery of these healthcare services. So that's a lot.
No. It's really, you said something that resonated very closely with some of the things that we see, and I want to ask you a couple of follow-up questions. So one of the things that you see is, because of the wireless communication within the four walls of these big and small hospitals, but particularly some of the big academic centers, all kinds of health systems, the internal wireless is challenging in a lot of different places. And because it's challenging in a lot of different places, over the last few years, you've seen the evolution of companies that are intended to help healthcare workers internal to their own system, their own buildings, communicate better. And there's almost a whole different level of technology that's been built as this intermediate step between sort of the general wireless and the much improved broadband 5G that you're talking about, as I understand what you're saying. So do I understand that right?
Yeah, you definitely do. It's come to where you can't rely on it inside of a hospital. And so that means you're limited in what you can do with these applications. But we're going to have a better system in the future. And it's something you'll have that level of security and reliability that you need in order to use these types of applications.
In the meantime, people are spending a lot of money, a huge amount of resources, to try and improve that interconnectivity wirelessly within the four walls of the hospital. At what point does the evolution towards 5G, makes that a game changer? Or is that really, it's not that foreseeable that quickly, so you better keep on investing internally now to make sure your communication keeps getting better and better? I'm just trying to understand and parse through that just one bit.
I think what we're doing today in terms of virtualizing the data center, virtualizing the edge, is getting us ready for 5G. And that's the infrastructure that you're going to need. And so I think we're going in the right direction already.
Thank you very, very much. Let's work through another question. Very helpful, Wendy and Andy. Thank you. Brad, let me turn to you and get you back involved. I mean, I love your perspective as actually being, in the trenches here. How does workflow optimization support digital transformation? How does how you improve workflows help you on digital transformation, or vice versa? And give us some, Brad, you're working in a huge orthopedic practice, some of the specifics of how you see people interacting using this and how you're trying to improve workflow with this, with technology and so forth.
Thanks. I think that maybe the best way to start off is by saying how it doesn't. And I think the way that it doesn't is when you try to use the same workflows that you've been using in your clinics for a number of years with a paper system, and then try to implement a digital system and force the digital system to be like the paper system. That seems to be really where we get stuck in the industry, is we try to just take a paper manual process or paper manual workflow, and then we just make it digital and call it a day. Really holistically looking at the overall workflow, from when the patient walks in the door, kind of tell that story, all the way to when the patient is leaving the practice or the surgical episode. That's really what you have to kind of revisit and see where the opportunities are to make things more efficient. When we made some significant changes to get completely away from electronic, or when we moved to electronic charge capture, that really changed a lot of our approaches on workflow, because it really kind of took chart, that super bill, that piece of paper out of the entire equation. The digital transformation is really enabling us to kind of revisit these workflows and see, what can we do? How can we make these things more efficient? And then kind of how do we have to kind of change our approach to a lot of these things? Because, there's sometimes, go ahead.
Let me stop you for 1 second, just because you mentioned something that is really intuitively easy for our audience to understand, that workflow optimization was changed dramatically when people moved out of the paper super bill and into some kind of electronic billing. Explain that for a second, what steps that took out of the equation, and then more so, a couple more examples where you saw specific changes in workflow that came out of technology.
Well, so there were a lot of, that super bill became the focal point of a lot of the visits, that did everything from, what patient to go see next to what x-ray was ordered. It was just, there were a lot of things that kind of centered around that, where the patient, what room the patient was in. And by removing that piece of paper, it really forced us to really revisit and optimize a lot of these workflows. That was just one example, but, the digital transformation has really changed the way that we approach a number of things, including, just the way that we see the patient, the way that we can get the patient in the office. I mean, a lot of what the challenges are, when you walk in and you have a stack of forms that you then have to fill out, and then that data needs to then be typed in by somebody. I think we really underestimate, how much more efficient it can be when that data can be entered in either before the patient gets there or in the lobby or in the waiting room before they even see the doctor, or the clinician. And that was just a huge change. Because having that data before you actually go in and see the patient, as opposed to having to review it with the patient, that really kind of keys in on that whole other idea of, let's take, paper or technology out of the equation and kind of reinstitute that human connection between the provider and the patient. So
let me ask you one more question on that. So let's say you're in a surgery practice, you're a hand surgeon, and I think Andy had mentioned earlier, we want to get away from the physician looking at his laptop and the patient being on the other side of that. And it's not so much laptop. Often it's the iPad today that he or she's doing his or her electronic medical records on. One, are all of your surgeons now and physicians, are most of them working off of iPads today and Lenovo tools and different kinds of tools and all kinds of things for entering into data? Is that what you're seeing today? What do you think?
So what we the way that we try to approach is there's all these different types of technology or tools, and we like to have a portfolio of tools that we support as an organization, and then from there we enable the provider to have the most effective workflow within their scope of practice. So, one thing that we did find very early on is by trying to pigeonhole every single provider into a small subset of specific ways of seeing the patients, it really it hindered their performance significantly. So what we do is we give them several different options, and whatever works best for them. Sometimes it's different based upon the type of patient. So they're new patients, which might be a longer that might be a longer interaction. They might need more data. They'll have one type of technology that they will utilize versus a recheck or a pre-surgical consult or something to that effect. So so really try to be it's flexibility, and that's really what technology enables us to do.
And it's really a lot of what Andy said. And Andy, maybe I can get you to comment on this for a moment, because this really goes back to the point you made about not forcing each physician or surgeon or nurse or PA to use certain types of technology, but having a policy that makes it and governance that allows some flexibility with that. Andy, is that a fair assessment of how the different practitioners use technology, or how you try and?
That's absolutely correct. So it's not only about having the resources in some kind of state that allows you to get to them from a myriad of devices. It's partnering with your different clinicians and your tiger team, your selection committee, if you will, in saying, okay, this makes a lot of sense, and this makes sense over here, and this makes sense over here, and thinking outside of the box and saying, okay, when I see, if I was in Bradley's practice and I was doing a follow-up on a knee, total arthroscopy, I might simply want the follow-up x-rays and to be able to dictate and not touch anything, so I may just want it on a wall panel. Whereas if I'm doing a pre-surgical consult, I may need all sorts of information, just as Bradley said. So understanding that, working with your clinical partners, and really stretching on how the information is delivered, and touching on what Wendy said, that delivery of information and that access to the different resources is going to continue to evolve and accelerate at amazing levels just in the near future.
And let me just ask you a question so I understand this from a hardware perspective. What kind of hardware is it that people are using in practices, hospitals, and so forth to sort of expedite this and make this happen? Just a few quick examples. We kind of look at it from three different perspectives, right? You have your edge. So what does the physician or the clinician or the technician touch? Is it a tablet? Is it a laptop? Is it a desktop installed in the room? Is it an all-in-one mounted on the wall? And it's all over the place, and it's devices running Windows, Android, iOS, Mac OS, and it comes. So when you use the term edge, and I hear when you use the term edge, what you really mean is the edge of where the physician or practitioner actually accesses it.
Correct. Where the end user touches it. The middle would be the infrastructure, whether that is the wireless networking, the physical networking, the access control systems, the security perimeter control systems, all of those. And then the back end, whether it be a traditional server, storage network, or some kind of hyper-converged infrastructure. You have all three layers, and as you begin to embrace these technologies, it frees up your choices at the edge or where the individual user touches it to make different choices.
Got it. Okay. So that's really helpful. And Wendy, let me come back to you on this question of sort of workflow optimization and digital transformation. Some of your observations.
Sure. I love these examples of optimized workflows. I have a couple to share. One is with using RFID to track patients or even assets in the hospital. We've seen that just the fact that you have tagged a person that's going in and out of the operating room, let's say, now all of the support team around the flow of the movement of that patient knows that we know that the patient has wheels out of the operating room. Now we know that we don't have time to waste. The cleaning crew can come right in. It's been recorded. You know exactly what happened when. There's no arguing over I wasn't ready or you weren't ready. This is exactly what happened. So tagging of assets and patients within the hospital can really help with pointing out where workflow inefficiencies are and helping to get you to that more optimal state. And then another example of a workflow collaboration tool that I wanted to bring up because it's made more possible through this whole optimization of the networking is with using a virtual reality or augmented reality. And this is the type of tool that can really make for a great experience for clinicians and the patients, allowing them to plan out, let's say for the clinician, complex surgery planning, where the practitioners can see and interact with the patient's anatomy and then identifying how the surgery will play out, where do they need to be careful, and they can do this as a team and use it as a communication between the radiologist, the surgeon, the medical staff, and even the patient, and allowing them to get a real sense of what's going to happen in their surgery. And that helps them with, out-migration reduction or the lessening of this medical tourism in the hospitals. improved surgical approach by 24%. I have numbers on all these things. And surgical conversion rate is also increased because you have a sense of what's going to happen. You're not going to be backing out as often. And so some of these tools are useful for workflow improvement.
So both this giving a sense of what's going to happen, which is as important as anything in so many areas of life, sort of forecasting, here's where we're going, here's what's going to happen. You mean these tools both for the patient and for the clinician?
Yes. Not so much the RFID tracking, except that the patient will now know what's happening more. And so it eliminates that wait time where they're sitting there not knowing what's going to happen. If we can, speed up these workflows, make it more seamless and following directly, so they know exactly what's going to happen. It eliminates a lot of their anxiety. And then with the virtual reality, and they can see inside their bodies and see what's going to be done to them and really understand why they need surgery. So yeah, it's for the patient and the clinician.
Fascinating. At what point, and I want to, we've got about a few more minutes left for the next question, and then I want to get to our audience questions. We have a bunch of them. At what point does the virtual reality discussion, you see it a little bit when you do some sort of endoscopic procedures where you could kind of see what the surgeon is doing. It's not quite virtual reality, but they kind of show you a little bit. At what point does that become more commonplace? And do physicians really want that to be commonplace? I mean, just a quick thoughts from you on that, and then I want to get to the next question for Andy.
Yeah, I think with 5G, it's going to make these devices smaller. That's where we get that some of the compute that's in these large virtual reality devices that you wear on your head could be pushed off, and they could be made lighter. That'll make it a lot easier to use, less cumbersome. And so that's coming. There's a lot of virtual reality being used today, even with the technology and the way that the devices look as they are now.
Great. Thank you so much. Andy, let me give you one last question. Then I want to move to our audience questions because we have a whole number of them. So thank you, and thank you for our audience for staying engaged, participating. Fantastic. Andy, how can workforce transformation support the industry's move towards value-based care? How do you connect these two, what you're doing technology-wise, workplace-wise, with value-based care? How do those connect?
So they connect in a number of different ways. I'm going to highlight just a couple of them very quickly because obviously there's a ton of questions I'd love to answer. The first way that they connect is that as we are seeing more interoperability, more just real-time communication, real-time delivery of information about the patient to the clinical care team, we are able to make broad, understood decisions about our delivery of care. So even let's say in Bradley's group, an orthopedist who is planning for a surgery finds out that there's a new diagnosis from cardiology or that they're able to say, okay, we're going to make these adjustments so that we can drive you towards recovery. The other component of that is the more information we have, the more we can actually determine what is my risk for this patient. What is the likelihood they're going to get well versus the likelihood they're not. I'm able to look at a patient and a patient community and say, this community is going to get well because I have access to their information. Therefore, I'm willing to undertake more risk. And risk is kind of the underpinning for how we switch to value-based care. As we switch from service to fee for value, there has to be some accommodation of risk, and that risk is going to fall on to the payers. It's going to fall on the clinicians, and some of that risk may end up falling on the patients themselves. So information helps us mitigate that risk or understand the scope of that risk.
Thank you. We've got just a ton of audience questions, and why don't we start with some of those if that's okay? I've got a great question, and I'll open this to the three of you. this question of digital overload, digital transformation, how do we get physicians in a spot, clinicians in a spot, where they're not so overwhelmed by what they're looking at on their screen that they learn to hit this right balance of dealing with their screen versus dealing with the patient? I mean, much of us hear about this in just our everyday conversation where somebody's looking at their phone rather than talking to somebody across the, that they're talking to. And how do you deal with this? Is there training for that? How do you get clinicians so comfortable that they're able to deal with their devices and deal with people as you hear patients concerned about the doctor's not paying attention to me one way or the other?
This is Andy. It's a transformative balance. And it is sometimes a rough discussion with a clinician to say, I want to put you through training. It's sometimes role playing. But a lot of it comes by starting at the executive level of any organization to say that patient engagement and patient satisfaction, whether we're driving for HCAHPS scores or whether we're driving for improved adherence of a patient to stay within our system instead of someone else's, if leadership starts driving, we're going to role play. You're going to play the role of the patient and perceive that. The other balancing factor there is, as you're working with your vendor partner, you have to ask them to, if I'm doing a follow-up on a patient for X or Y or Z, I only want to see that information. If I'm seeing a new patient or a new situation, I may want more information. So creating workflows that expose you to the appropriate information without overloading for each individual's specific set workflow will help control that.
That's a great point. So two things. It's leadership constantly embarking on. This is about patient experience, patient engagement. And two, it's something Wendy said earlier, you said earlier, Brad said earlier, about making sure the clinician has the right information, not all information. That's just a great point. Brad, let me ask the next question to you, and then Wendy, I've got a question for you. Brad, the next question becomes the balance of bring your own device and the ability for people to have everything they want to have versus security concerns. How do you balance those two to help avoid phishing, unwanted access to the network, hacking, those kinds of things? How do you balance access and bring your own device with cybersecurity?
So I think that there's a few different things, because I think we've all learned from the proliferation of devices that having an extremely restrictive policy really prevents people from using, and then they'll just figure out ways to circumvent that. So really what the best way to do it, at least from our perspective, is we really something that you'll hear a lot is called zero trust environment, and that's pretty much the approach that we have from a mobile device perspective. So effectively, if we can't, if it's not one of our devices that we have put the technology on, we're just going to assume that that device is could be compromised, possibly compromised, and put it in a basically kind of wall it off so that it can only access what needs to access. I mean, a lot of the times, if you can just have a governance structure and an architecture that supports giving people only access to what they need, you'll be so much better off, because at the end of the day, if they're only able to access what they need to access from the devices that they should be accessing it from, you're so far ahead of the game from a security, from a hacking perspective, just because this is not, this is data that needs to be as accessible as possible to the right people, and that's kind of at the end of the day the mantra, and that's kind of the big challenge that we have to deal with is, at the end of the day, our main goal is taking care of the patient, and that's that has to resonate at all levels of any governance or security architecture.
But you do. I mean, as I hear you say this, that you try and make sure that with any device, mobile device, bring your own device, very aggressive in trying to wall it off so that device can only access part of the system or what they need to access, and you can't just let anybody's device in an unfettered way access your system without it being part of your governance and architecture.
Correct. So you can support multiple device types, you can support multiple solutions. I mean, the ubiquity of MDM solutions now support just about everything. So, again, tying back into virtualization, we are very heavily leveraging virtualization. So when you virtualize things and you create the right governance around access and controls, then it makes that whole process much easier. So, you don't need to restrict people down to specific devices if you have if you have the proper governance and architecture on the front end of allowing people to only access what they need to access.
Got it. Wendy, let me ask you a couple of questions that tie into sort of artificial intelligence and care coordination. How would you characterize AI as it's being applied to care coordination? And how do you provide patients some comfort that AI is not going to be used in some way that they're uncomfortable with, or that's going to, somehow or another share their information improperly, or whatever it might be?
Yeah, one thing is we're looking at using blockchain to track where the data came from that you used to come up with these insights used in artificial intelligence. So that can open up that black box that AI is, where you feel like, well, where did that idea come from? And then you can use blockchain to go back and say, okay, here's the data points. This is where the data came from, and it gives you a better sense of comfort. Gives the FDA a better sense of comfort as well in terms of approving these new solutions. And I wanted to comment on...
It's a fascinating comment, though. Fascinating comment that essentially you're going to use AI, which is going to go through reams and reams and data from all kinds of places to get you to suggestions or solutions. And the idea being that by having a more lockstep blockchain type order, you could actually at some point track back to where did that suggestion come from? What were the analytics that drove that suggestion? And that's a fascinating understanding for us as we're all trying to learn how blockchain is going to be applied. So fascinating. You were going to make another comment. I just wanted to summarize that to make sure I heard it right and understood it, but fascinating. You had another comment to make.
The other thing I wanted to say was back to how we're helping clinicians with their workflows with AI and giving them less, giving them more time with the patient and being able to work with them face to face, working with the right patients. So when you have radiologists, you have a limited number of them and a limited amount of time that they have. And there are more and more images being generated. The AI is a key tool that we can use to identify those images that have lesions, that have cancer probability. And those bubble to the top, and then you can, with the rest of the cases, you can have a less experienced clinician working on those and working with those patients. That way the radiologist that needs to work with the crucial problems has more time, because their workload is limited down to maybe 30% instead of the 100% of the cases. Sorry, go ahead.
Well, let me do this, just because we've got a whole number of questions. We've only got about 6 minutes left. I'm not sure if Andy or you is the right person for this question. You've both touched on it some. Let me try Andy first and then come back to you on this, but just, if I can, try and get you each to 30-second answers each so we keep on working through questions. And of course, there are questions that could take 20 minutes to answer. How to leverage unified communications to do better care coordination? How do you leverage unified communication? The question is, the system's moving beyond 4G to 5G. Presuming that will stabilize, will the communications stabilize with good distributed antenna system, DAS? Andy or Wendy, you may understand the question better than I do, and maybe one of you could jump in and try and respond to that.
Wendy, do you want to go first, or do you want me to go first?
I'm not sure what DAS is.
I wasn't sure, but in the question it was set up as a term of art, and I'm not.
Distributed antenna systems. I see it.
Yeah.
So I'll get started. So with all communication, right? It's about transmission, reception, and reliability. And whether we're talking about distributed antenna systems, or whether we're talking about the actual power of transmission and power of reception that we're going to see with 5G, we're going to see an increased reliability. And with that increased reliability, we're going to see an increase in the functional usage of communication, whether it be communication of our applications, communication of our resources, or peer-to-peer, clinician-to-clinician communication. So I'm not sure I'm answering the question, but I think that the fundamentally we're talking about reliability promoting use.
I think that's a great point. Go ahead, Wendy. Thank you.
Yeah, I agree. That's 100% what's going to happen. I think some of the use cases that you're going to see are more use of telehealth because you can rely on it. We'll be able to do things like remote surgery with maybe even robotic because you will be able to rely on that not getting a breakdown between when you started and when it's over. You need to have it maintained. You're going to be able to use it also for extending the reach of those specialized clinicians and allowing them to work with more patients in a command center type of approach. Those are just a few.
It's a fascinating thing because all of us can understand it in our daily lives, from trying to make sure the laptop doesn't go off during the webinar to making sure during an important phone call our phone doesn't go off, to you're advancing this to a much more life and death situation to make sure the robotic system or digital system doesn't go south in the middle of surgery, and make sure you've got backup plans. So with a much better system for communication and better improved interconnectivity, you just increase your reliability and chance to be able to do the things you really want to do well and with lower risk. Fascinating. I've got one more question I'd love to ask. And Brad, this goes to yourself. In terms of, does your system integrate all processes related to holistic patient flow processes that you mentioned? And is the information accessible to all clinicians at all times, or is it limited by types of clinicians? And I know in some systems they limit it for HIPAA reasons and privacy reasons and so forth. How do you deal with some of those rules? And then Andy and Wendy, I wanted to come back to you one final time after I get Brad's answer on this.
Thank you. Yeah, I was going to approach that question from a few different ways, and I know we're running short on time. I think kind of the key thing is one benefit of being a single specialty orthopedic practice is, all of the people that are involved in the care are, orthopedists or supporting, from a rehab, from rehabilitation to imaging to the surgical center. So there's not so much cross-functional teams. So from that perspective, we allow clinicians, as long as there's a medical necessity reason, to have full access to the patient's charts to be able to make that clinical decision. There definitely is limitations based on roles and who has access to what, but for the most part, I would say that there's still limitations in a lot of the systems, from actually creating because the problem that you run into is when you create too much granularity, it becomes a nightmare to manage and maintain. So it's kind of like, it's that fine balance between, basically building some taxonomy that pigeonholes people into very specific access levels versus, taking care of the patient, which is, at the end of the day, is the main thing. So, from a HIPAA perspective, go ahead.
But no, your point is very well taken, because what happens with this, and we hear it all the time, the more restrictions you put on what, for example, email gets through, the more you miss important things that the patient might need. The more restrictions you place on what clinician can get what information, the more challenges you have in actually making sure that clinicians get the information that they need. And so your point is really well, I think that's the point you're making. It's really well, it makes a ton of sense. So thank you.
Okay.
Let me do this. I think great. And so I mean, Brad, I take it it's a constant balance. Andy, Wendy, let me give you a second for closing thoughts, if you have any at all. Lenovo is just in the middle of this every place throughout the healthcare world. Intel touches all of us. We're all used to Intel Inside, and now we see it through commerce, business, huge health industrial complex, great health systems, academic medical centers, and so forth. Lenovo Health the same thing. Any closing thoughts on where this is going and sort of interconnectivity and improvement for patient care and clinician care?
I just want to say thank you for the opportunity to discuss all these new technologies and ideas about how we can improve workflows and collaboration. And I love that all these folks are on the call and interested in learning about how to make the healthcare experience better.
Thank you very much. And I know our panelists, Wendy, Andy, and Bradley, our sponsors, Lenovo and Intel, one, did a wonderful job of making this not commercial oriented towards them, but really informative for our audience. It shows by the fact that our attendees stayed on the entire call. Very few left early. Andy, we're extremely thankful for your leadership here. Anything you wanted to leave the audience with?
The only thing I would leave the audience with really is not only my sincere appreciation for their attention and their participation and their dedication to the patients and what we're doing here, but just a great optimism and confidence in where healthcare is going and the delivery of care, whether it's the technology that's empowering the clinician, the dedication of the staffs that are using this technology, or the commitment that I'm seeing across the globe of patients willing to engage in their own care. I have a great optimism for where the future is going.
Thank you very much. I feel blessed to have a chance to visit with the three of you. I feel like I learn so much every time I get a chance to do this with you, so I appreciate it greatly. And we'll follow up with you shortly. I want to again thank our audience so much for joining us. Just magnificent and so many questions. I'm sorry we didn't get to all of them, but hopefully we'll get a chance to visit with more of those questions on following webinars, or obviously you're free to reach out directly to Lenovo and Intel and so forth. And Brad, I won't put you on the spot for that, being that you've got the day job to run at Resurgence and run all of their tech. But we appreciate our audience's questions greatly and appreciate all three of you being on the webinar today. Thank you folks so much. Take care.
Thank you, Scott.
Thanks all.
Bye-bye.